In this very first session, ladies and gentlemen, we are honored to have the representative from Riken Center for Integrative Medical Sciences. And without further ado, may I introduce to you Dr. Mushi Roda, ladies and gentlemen.
Good morning, everyone. Today, I will talk about development of a targeted next-generation sequencing panel, PKSEQ, and how to apply the panel to pharmacogenomics research. Pharmacogenomics, PGX, is a created word with pharmaco, that means medicine and drug, and genomics. It is well known that genetic variation contributes to inter-individual differences in drug efficacy and risk of adverse drug reactions. So, using the genetic information in hospitals, medical doctors can do genotype-guided drug therapy. Namely, doctors can judge whether the drug is appropriate for the patient or not, and obtain information about appropriate dosage and risk of adverse drug reactions. Actually, PGX can help patients in two kinds of aspects. One is prediction of toxicity, such as skin rash and liver injury. The other is prediction of efficacy, such as warfarin or apalib. But today, I will focus on the prediction of toxicity. For example, please assume 100 patients who need treatment with anti-epileptic drug carbamazepine. In Japan, about 5% of patients with red color are reported to suffer from skin rash induced by carbamazepine. Using a genetic test, at present, unfortunately, we cannot identify these 5 patients accurately. However, we can select the patients with high risk of skin rash induced by carbamazepine. In these patients, by avoidance of use of carbamazepine, we will be able to reduce incidence of skin rash. This is a scheme of stratified drug therapy based on pharmacogenomics. This slide shows the fate of drugs in human body, so-called pharmacokinetics. When we receive the tablets or capsules, the drug is absorbed from small intestine and moved to liver, systemic circulation, and then distributed to target organs. So, higher drug levels in blood will lead to higher tissue distribution of drug, leading to higher efficacy and or higher toxicity. Therefore, it is important to examine drug levels in blood for evaluation of drug efficacy and risk of adverse drug reactions. Also, drug levels in blood are affected by drug metabolizing enzymes and drug transporters. In case of human liver, in hepatocytes, drug is cleared by drug metabolizing enzymes and drug transporters involved in uptake of drugs from blood and excretion of drugs into bile duct. So, many drug metabolizing enzyme and transporter genes are responsible for pharmacokinetic steps and affect systemic exposure to drugs. This slide shows website of US FDA, and in this website, we can see a table of about 400 PGX biomarkers in drug levels approved by US FDA. According to the breakdown, 113 somatic tests and 269 germline tests are included in the table. Actually, drug metabolizing enzymes and drug transporters account for more than 50% of germline genetic tests described in the drug labels in US. GBAS, genome-wide association studies, should be a powerful tool for genomics and has contributed to identification of many SNPs associated with disease susceptibility and drug responses. However, among about 2,400 GBAS published, pharmacogenomics studies account for only 8.8%. One of the reasons should be weak points of SNP array used for GBAS. I'd like to tell you the weak points of the SNP array. Firstly, rare variants are not included in most of SNP arrays. In addition, even though common variants, genomic regions with high sequence homology, such as cytochrome P450, are difficult to be examined by SNP arrays, but NGS can look at these regions. In this table, I summarized important pharmacokinetics-related genes, including 60 drug metabolizing enzymes and 37 drug transporters, and NUDT1, NUDT50, and VKORC1. However, most of these genes are located in regions with complicated structure, so it is difficult to analyze these genes by using SNP arrays. So we developed targeted NGS panel, PKSEC, by combination of multiplex PCR and next-generation sequencer, Illumina MiSeq. Using this panel, we can detect common and rare variants in these pharmacokinetics genes. This slide shows workflow of PKSEC. One of the important points is that more than 1,100 primer sets were divided into 8 pools, and then multiplex PCR and purification were conducted in parallel. In addition, concerning copy number variations of 6 genes, CES1, SHIP2A6, SHIP2D6, GST-M1 and GST-T1, and SOUT1A1. At present, we conduct a Tuckman assay. This slide shows the number of corrected reads and the copy number of the 6 genes. You can see clear discrimination between copy numbers. However, in cases of CES1 and SOUT1A1, it is difficult to discriminate 3 copies from 4 copies. So we still need Tuckman assay for accurate determination of copy number variations in CES1 and SOUT1A1 genes. Maybe you would like to say, why don't you use whole exome sequencing or whole genome sequencing for examination of the pharmacokinetic related genes? For example, One of the important drug metabolizing enzymes, SHIP2A6, has high sequence homology with SHIP2A13 and pseudogene SHIP2A7. This slide shows result of mapping of SHIP2A6 in the pKsec and whole exome sequencing. pKsec shows no existence of a variant, but in case of whole exome sequencing, we can see sequencing error due to mapping of pseudogene sequences, maybe due to shorter read length of whole exome sequencing compared to pKsec. Today, I'd like to show the result of comparison between pKsec, whole genome sequencing, and whole exome sequencing, focusing on very important 22 core genes in pKsec, phase 1 drug metabolizing enzymes, including SHIPs, phase 2 enzymes, drug transporters, and NUDT15 and VKORC1. This slide shows comparison of whole genome sequencing and whole exome sequencing with Sanger sequencing about difference allele homozygotes, heterozygotes, and variant allele homozygotes detected in the 22 core genes. As you can see, there are several discordancies with Sanger sequencing, leading to only 9% of accuracy for detection of the variants. This is a critical problem, not only for pharmacogenomics research, but also for clinical implementation of next-generation sequencers. In case of pKsec, there were no genotyping errors in comparison with Sanger sequencing, indicating the advantages of comprehensive and accurate assay of pharmacokinetic-related genes, high throughput, and low cost. Next, we applied the pKsec to non-Japanese samples, Chinese, Caucasians, and Africans. Please see the bottom line of the table, showing the number of detected genotypes and concordant rates to 1,000 genomes data. We obtained comparable performances and accuracies in the 4 different populations in the world. Again, SNP array is not always useful for pharmacogenomics research, and I'd like to show the example. We collected DNA samples from patients with ovary, uterus, and cervix cancers, receiving paclitaxel and carboplatin therapy, including 50 cases with severe hematotoxicity induced by carboplatin and 270 tolerant controls. When we conducted GBAS for hematotoxicities induced by carboplatin, we could not observe positive signals in the Manhattan plot obtained by the GBAS. This slide shows result of association study by pKsec, and GSDP1 SNP showed the lowest p-value. In this SNP, case group showed higher frequency of AA genotype, namely isoleucine homozygote, compared to control group, 94% versus 72%. In addition, when we examined the effects of the GSDP1 SNP on efficacy of carboplatin therapy, isoleucine homozygote shows significantly better efficacy of carboplatin treatment. These results indicate that we have to keep in mind that both toxicity and efficacy should be evaluated in pharmacogenomics studies at the same time. The result can be explained by activity of GSDP1 that converts carboplatin to glutathione conjugate. In case of isoleucine type, GSDP1 activity should be lower, leading to higher systemic exposure to carboplatin and higher toxicity induced by carboplatin. In opposite, in case of valine type, higher metabolic activity will be responsible for the lower systemic exposure and lower toxicity of carboplatin. Also, higher systemic exposure may be responsible for higher efficacy of carboplatin treatment in patients with ovary and uterus cancers. I will show another application of PKSEC. As all of you know, CYP26 is one of the most important drug metabolizing enzymes because many major drugs are metabolized by CYP26. Actually, CPIC issues 6 guidelines for CYP26 substrates that are very important drugs in clinical. In particular, when we read a drug label of the new antipsychotic drug, brexpiprazole, important information is described in the drug label. In case of non-CYP26 metabolizers, the dosage of brexpiprazole should be reduced to 50% of usual dosage. This means the CYP26 test should be a companion diagnostics that must be absolutely conducted before the start of administrations of brexpiprazole. When we genotyped 919 Japanese subjects for CYP26 using PKSEC, we observed 83 already known diplotypes. However, we could not determine the haplotypes and diplotypes of 17 subjects due to novel 14 variants identified by PKSEC. As you know, the sequencing of CYP26 has been conducted since 1980s, namely has more than 30 years of history. We are very surprised that we could identify such many novel variants by genotyping only about 1,000 Japanese subjects. This slide shows the novel 10 CYP26 haplotypes based on the information of novel variants and results of long-read sequencing. Yellow box represents exons that have already known variants, and red box indicates exons that have novel variants identified by PKSEC. Of course, we registered the 10 novel haplotypes of CYP26 to PharmBar database. You can visit the website and see the detailed information about the novel variants, haplotypes, and our publication. In addition, we determined in vitro CYP26 activities of the 10 novel haplotypes using dextromethorphan as a typical substrate. 6 of 10 haplotypes showed extremely lower CYP26 activities compared to wild-type CYP26 allele *1, and 3 of 10 haplotypes showed activities under the detection limit of the in vitro experiments. These results indicate that most of the novel variants contribute to the reduction of in vitro CYP2D6 activities. Based on the in vitro CYP2D6 activities, we recalculated the activity scores of CYP2D6 in 17 subjects and corrected CYP2D6 phenotypes as shown in fourth and fifth columns. Eventually, 5 extensive metabolizers were changed to intermediate metabolizers, and 4 intermediate metabolizers were changed to poor metabolizers. These results will provide useful information for patients who are scheduled to be administered with drugs metabolized by CYP2D6. This is my final slide to show future direction of certified drug therapy based on pharmacogenomics. Using patients' blood, saliva, and nail, genomic analysis is conducted using NGS and PK-seq panel, and genomic information will be collected by cloud-based networking and then provided to hospitals. In order to achieve such certified drug therapy, we will continue to make effort for identification of pharmacogenomics biomarkers as many as possible. That's all. Thank you for your attention.
Thank you very much, Dr. Mushiroda. Thank you a lot. Thank you a lot for your sharing and your informative presentation. I believe that our audience out there have learned a lot. I would like now to bring all ladies and gentlemen to our Q&A session that I informed all of you earlier. There is a Q&A box for ladies and gentlemen to leave some comments as well as some questions. And we've got a couple questions for Dr. Mushiroda. Would you please?
Okay. Good morning, Dr. Watson. Watson Sensei. Can you hear me? Can you hear me? But should I read the content of the questions? Okay. 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 First question is, what is the approximate percentage of adverse drug reactions with genomic associations? I guess percentage means the frequency of the adverse drug reactions. When we conduct GBAS, we use 2 groups, case group with adverse drug reactions. Okay, can you hear me? Okay, again, in case of GBAS, we use 2 kind of groups, case group with adverse drug reactions and general control Japanese group, because it is difficult to collect tolerant controls by medical doctors. However, in this strategy, in case of adverse drug reactions with more than 30% of frequencies, such as neutropenia or leukopenia induced by cancer chemotherapy, this strategy is very difficult to detect the associated SNP. So, from the viewpoint of the statistical analysis, we expect about 5 to 10% of the frequency should be good in order to find out the positive signal in the GBAS of the pharmacogenomic study. Okay, second question is, could you please throw some light on best statistical method to perform GBAS? Usually, we conduct GBAS with 3 genetic model, allele frequency, and dominant and recessive models. And then we usually employ the lowest p-value obtained in the 3 models. This is our best method to conduct the GBAS for us. And the third question is, what is the per sample cost of PK-seq? Previously, we calculated the cost of the PK-seq, and without the Tuckman assay, $42 per 1 sample is necessary for the PK-seq analysis. In addition, if we conduct the Tuckman assay, total cost should be about $80 for 1 sample. Okay?